This is a very, very long presentation. I have to warn you that we're going to talk about a lot of things. We're going to talk about the cavernous sinus in a very wide perspective. I'm usually trying in all my presentations to give you an accurate description of everything that the cavernous sinus is when it comes to anatomy, but also when it comes to approaches, because the cavernous sinus is something that, you know, it's like a border zone where people, or some people will dare to get into the cavernous sinus and some of them won't. But the idea nowadays is that we're not going to just operate any lesion in the cavernous sinus. What we're going to do is we're going to think very clearly about it, and then we're going to make an informed decision based on the patient specific. So the idea is, and I think, yeah, we're at the Walter Dandy Society, I think Professor Orbital keeps saying this in his presentations, the essence of neurosurgery nowadays is to focus on patient outcome. So you're going to become neurosurgeons, or you are neurosurgeons, and the only thing that matters is the patient outcome. That's the only thing that matters. It doesn't matter if you can do a perfect resection of a tumor in the cavernous sinus and leave everything intact, but the functional outcome is poor, is appalling. That's not going to help your patient, and that's not proper surgery. You're a bad surgeon if you do that. And that's also the reason why we're getting into subspecialties nowadays, and that there's no concept of a neurosurgeon that's going to do everything, as you know, the forefathers, Anterior or Cushing did. But we're trying to subspecialize, and the subspecialty is, it has a specific point. The point is that you're going to become the best in something you like, and you're going to like what you're doing, so you won't really have to work, and you're going to become the best, so your patient outcomes will be perfect, or as close to perfect as possible. So the cavernous sinus is a region that's going to be reserved for people that are going to operate in and around the sella. Because what we're talking about is the region of the sella and the paracellular region. That's the anatomy. So the anatomy is basically the same since 1760. This is a drawing by Zinn, Johann Zinn, that was a botanist and also an anatomist, and he focused on the orbita. And if you look at this dissection, you see that he actually managed to see all important structures, like the sixth nerve entering the Dorellus canal here, or the anterior clinoid, and even the orbita is beautifully dissected. So what has changed in 1760? Basically nothing. Now, what is the cavernous sinus, and why is it called a cavernous sinus? I'm pretty sure some of you, if not all of you, have wondered, what is the cavernous sinus and why is it called a cavernous sinus? Well, Galen, he considered it a retia of many substances where nerves and venous plexus come together, but he also considered that the carotid artery forms a rete mirabile in the head. And what is a rete mirabile? That is like in the kidney where you have a glomerule. So you're trying to keep the medulla of the kidney always hypertonic. So that's a rete mirabile. It's also called a port system, and you have that at the hypophysis, you have that at the liver, you have that on short port system at the kidney, and you also have that in the sheep, because in the sheep and in other mammals, the carotid forms here. This is the anatomy of the sheep, and you can see here prehistoric basal artery, and also the rete mirabile in the head. So he thought, upon looking at the carotid plexus in the neck, erroneously, that the carotid also forms a rete mirabile in the human head, which was undisputed for about 1300 years, because nobody dared to dispute what Galen said, because he was the founder, or one of the founders of anatomy. But if you look at a paper that's been published in 2007, you see that some people actually do have a lithium labile in their heads. This is a carotid artery, this is an angiogram, and you see here all sorts of small petrous vessels coming from the ascending pharyngeal, the maxillary, and all coming and anastomosing here. So there are some people where there is a lithium labile, there's a basilar artery and vertebral that's also forming lithium labile. It's usually pathological only in time, because it's usually a point where people get an ischemic or an hemorrhagic stroke. But until that point, they function properly because the blood supply to the carotid, to the distal carotid is ensured. So it's pathological, but it can happen. It's a congenital abnormality. Now this guy, Raymond de Vicence, in 1790, he described the cavernous sinus better, but the one that actually named it was Winslow. And for those of you who know a little bit about abdominal anatomy, he's the one that has the foramen of Winslow behind the hepatic pedicle. And what he said is, in his book, Exposition Antique Humaine, he said that that upon searching the sella and the paracellular compartment, he came across plexus of veins with vessels and the carotid artery, which resembles the cavernous bodies of the penis. So he named that cavernous sinus. So it's actually, its name comes due to Winslow's comparing it to the cavernous bodies of the penis. I want to talk a little bit about the osteology of the skull base, so we'll know what we're dealing with. And I'm not going to insist about everything, I'm just going to insist about the sphenoid and the ethmoid bone. This is a model it's one of, that's been thought out by a very great anatomist, that's Professor Santini in Tours. And he said, you know, if you want to imagine the sphenoid bone and you want to know about it, just imagine a cube, shape the sella and the sphenoid ostia, then just attach two pterygoid plates, medial and lateral, then attach the anterior clinoid and the lesser wings and then the great wings, and you have a sphenoid bone. And if we look at it at a frontal 3/4 dissection, then you're going to see that it's basically the same idea. So if you keep this in your head, then you'll always have about estimation of what the sphenoid bone has to look like. This is probably a bit easier to remember than this. Now, Professor Lang, that's also one of the people that always did in their lives what they wanted and what they loved most, and he loved most the anatomy of the skull base, and he was one of the anatomists that studied the skull base, and what he saw is that the ossification process of the sphenoid bone, it happens in at least 10 centers. Why is that important? Because that leads to a lot of variability in the anatomy of the patient. So we heard before that you always have to get a CT and you have to do a bony window. What do you do? Because you want to see what the anatomy of your specific patient is and how that anatomy is going to influence your approach. Because the septa and the lesser wings and the clinoid process, they're always going to grow in another direction or in another way. So you have to know that before you go in, so you don't have any surprises. Now the ethmoid bone, that's pretty simple. You just take a perpendicular plate and a vertical plate, and you add a labyrinth and lamina fibrosa and the crista galli, and you have an ethmoid bone. And if you put them together, then you have the central skull base. So what we're talking about today is actually this area and this area, the sellar and paracellular regions. This is one of the books of Professor Santini for everybody that's interested in more about anatomy and surgery from a great professor. Then maybe you should read this. He was a professor in Tours, but he's now retired. So, if we are to continue with our gimmicky skull base, then if we add a frontal bone and maxillary bone, and then we also add palatine bone and the nasal turbinates, we ultimately have the route that you're going to be taking when you're doing a transnasal approach. If you look at a sphenoid from an anterior perspective, then you're going to see that this is the planum, and the tuberculum we're going to be talking about in a minute. And what you also want to remember is that this is foramen rotundum, which opens in the pterygopalatine fossa. And if you look at it from a posterior perspective, then you see that it's not vertical, it's actually horizontal. So that's very important when you're going to, because we're going to be talking a lot about this region today. So we're going to have to try to make a 3D image of what this is, because when we're talking about approaches, I'm going to tell you about some of the difficulties that beginning trainees have when looking about the anatomy of this region. And this foramen valley, this dorsum celli, the anterior pinal process and the posterior pinal process. Now, I told you about the Ossification Center, so what you see here is a normal cellular anatomy, or is it? Because on this side you have a normal cellular anatomy, and on this side you have a very important variant. So what we're seeing here is the flenum sphenoidale, we're seeing the anterior clinic process, we're seeing the optic strut, we're going to be talking about it in a minute. And what we also see is the middle clinic process. Now, there are some authors that say that the middle clinic process is sometimes absent. It's never absent. Sometimes it's just very flat. So it's never actually absent, but sometimes it's just very flat, so you don't see it. But sometimes it grows and it becomes connected to the posterior clinic process and the anterior clinic process. And what you get when you have this situation is you have a carotid-clinoid foramen. And why is this all important? Well, the carotid artery passes here in its clinoidal segment. We're going to be talking about it in length. But it passes here, and what you're doing when you're doing a transcavernous approach is you're drilling out the anterior clinoid process, as you'll see in a movie in a few minutes. And the last step to the drilling of the anterior clinoid process is removing the tip. But you can imagine that if you're drilling this out, and you have here the optic nerve that's exposed in the carotid here, and if you pull too hard on this one and you're too enthusiastic, then you're going to be breaking the carotid. And why do you have to take this into consideration? Because this happens in 31% of people. 31% of people have incomplete carotid-clinoid foramen, and 18% have a complete carotid-clinoid foramen. So if you're doing an anterior clinoidectomy, there's an 18% chance that if you don't look at a CT, you're going to be breaking the carotid artery if you're too enthusiastic. Professor Keller is one of the neuroanatomists at the Mayo Clinic, and he's one of the inspirations of this talk, because I've seen a lot of talks about him, and he's actually he's just the neuroanatomist. He does nothing else. He's also linked to the Department of Neurosurgery, where all great skull-based surgeons have went to him. Theodopoulos from San Francisco, Sebastian Froelich from Strasbourg, now in Paris, taking over with Bernard George, and everyone who's anyone, John too, author of the great books together with Harry van Loveren. Everybody who's anybody has collaborated with Jeffrey Keller, and Jeffrey Keller has amazing anatomical articles, because anatomy, what you're doing when you're doing your research, it's not you're writing a Rotan book, and don't get me wrong, Rotan's a genius, and I love his work, but it's not all about writing a book and anatomy's Gray's Anatomy and that's it. No, anatomy, if you're really going into that, if you really like the idea of going into the lab and researching and drilling cadavers and looking at anatomical variants, that's publishing in anatomical papers. So the next step beyond reading Rotan is researching anatomical papers, and there's so many of them that you actually have to be very precise when and what you're reading. So that's why you go to courses, to learn from other people who have studied the cavernous sinus. What should you read, and what direction should you take? And the same for temporal bone or for Petrus bone. So what he saw is, you have the ethmoidal spine, you have the planum, obviously you have the tuberculum, And you have this ridge here, that's called the limbus sphenoidale, and the chiasmatic sulcus. Now, the chiasmatic sulcus does not really host the chiasm. The chiasm is a bit more posteriorly to the chiasmatic sulcus. In some of the cases, it's above the chiasmatic sulcus, but in embryological development, the chiasm is there. So why is this for importance? Why would anyone do an anatomic study of the prechiasmatic sulcus? It just seems so random. And they found 4 types. You see, you can have a very steep, narrow, or you can have it very flat, or it can look like a valley. Now, why is this important? Well, if you look at the first type, which is more common than you might think, then you see that there's a very shallow groove that's going underneath it, and that's going to host dura. And when you're operating on a meningioma, there's also meningioma that's going to go underneath it. And if you don't think about this, and if you're not looking underneath it, it's going to come back later in your office. He's also looked at the optic strut. Now, the first question is, what is the optic strut? Once again, we're looking at sphenoid bone. This is the anterior climatic process, and the anterior climatic process has 2 roots. And the first root is just the roof of the optic canal. So this is where the optic nerve enters to go into the orbit. And the second root to the basisphenoid, this is basisphenoid, is the optic strut. Now, the optic strut is a very important landmark because it's actually the one that separates the optic canal from the superior orbital fissure. And that's going to become very, very important when you're doing a transcavernous approach, as we're going to see soon. Now, what he saw is that obviously no 2 people are alike, and that you can have an optic strut that's very well hidden underneath the anterior climatic process, pre-sulcal. That you have some cases where it's sulcal, post-sulcal, or even asymmetrical. And this is in about 44% of the cases. This is about 33% of the cases. Now you can imagine that if you're going here to do a transcavernous approach and you're expecting the optic strut to be here and the carotid to be here, you're going to not expect this. You're going to be drilling and at a certain point you're drilling into the epineurium of the optic nerve, and you're going to be asking yourself, why? This is why. Now we're going to be talking about the actual cavernous sinus. What is the cavernous sinus? That's a question that has been plaguing anatomists and neurosurgeons, I think, starting in 1965 with Parkinson, and all the way today. We do not have a complete view of what the cavernous sinus is. But let's just say it's an epidural space. So the cavernous sinus is not really a sinus, in that it's not. There are a lot of people that say otherwise, but there's a common theory that's emerging nowadays that it's actually not really a sinus, because a sinus is a venous space that is enclosed by 2 layers of dura, but it's not actually a sinus because it's not really intradural, it's epidural, so it's outside the dura. So the cavernous carotid, which is going here, is not actually intradural, but it's actually extradural, and that's very important for aneurysms and for other processes that are going on here. So let's just get oriented first. You see, this is the carotid sulcus, this is the sella, this is dorsum sellae, this is the clivus, petrous apex, the lingula, the sphenoid bone. Now you have at least 3 lingulas in the human body that you have to remember. And one is the sphenoid bone, one is the lung, and the other one is a part of the vermis of the cerebellum. But we're going to be talking about that tomorrow. This is foramen rotundum, and it's important because at this level you have a heterolingual ligament. Those of you who've read Rotten probably heard of this and don't really know what the importance of it is. Well, it marks the end of pars lacerum of the carotid. So, in other words, it marks the entrance of the carotid artery into the cavernous sinus, which is a very important landmark if you're doing skull-based surgery and if you're drilling around the petrous apex, as we'll be seeing tomorrow in the Kawase approach. This is the foramen rotundum. And this is the inferior limit of the cavernous sinus, which is also represented, we're going to see, of V1. And if we drill out the anterior clinoid, we're left with the optic strut. And we're also having a direct connection to the superior orbital fissure. This is all going to be very important soon. Now, I can't talk about the cavernous sinus without talking a little bit about embryology, and I can't talk about embryology at the Walter Dendy Society without mentioning Dorcas Paget, who was an amazing anatomist. At that time, that was, let's just say it's politically correct, there was no benevolence from the masters, Cushing and Dendy, to let women be neurosurgeons. So he decided, he realized what the potential this woman had. So he said, okay, I'm going to hire you as embryologist and I'm going to let you draw my operations. So she was a very close collaborator to Dandy, and she was very, very appreciated by him, but she was never a neurosurgeon. But what she did, and this is really, this was so big, and this is so important that it has not been reproduced to this day with all our skills. And what she did is she studied a lot of fetuses, and she actually drawn out the arterial and venous embryology of the head. So what you know now of arterial and venous embryology inside the brain, you know from her, and nothing has changed. If you read the latest book of neuroembryology, they're not saying anything different than she has did. What Professor Keller says, and where I agree, she says that the cavernous sinus is forming lately. She defines, it's very complicated. She published 2 compendia on this subject in 48 and 56, and those are really difficult books to read. It's only if you're a dedicated anatomist that I really recommend that you read them, but they're very complex. So she defines 8 steps in venous development of the brain, and she says that the cavernous sinus only occurs in the late phases, in the 7th, so in the 7th phase. But I think, and I get this from Professor Keller, he says that if you look here behind the Gasserian ganglion, which is forming and behind the optic capsule, you can see the beginning of the cavernous sinus even here. So no disrespect to Dorcas Paget, she got everything right except when the cavernous sinus is forming. And if you look at this article, which nobody knows because it's published in the Japanese neurosurgery, which nobody reads, but this is an amazing article on the developmental of cavernous sinus, and it's actually so good that it's almost not being reproduced. So what the Japanese did, and they also have a lot of resources, they have a lot of people, but sometimes they just have no intention of publishing in American or international journals, so they just publish in this paper, this journal, which is amazing, but it's just filled with Japanese neurosurgeons, and sometimes they're in Japanese, so it's a bit difficult to read. But what you see is this is the development of the cavernous sinus, and this is 16 weeks. You see the trigeminal ganglion, you see the apex of the Peters bone, you see the meningeal layer, you see the pituitary gland, you see the sphenoid bone, which is just cartilage at this point, and you see this. Some people say that this is a periosteal layer of dura. Now, let's talk about this a minute. When you have bone, you have periosteum. That's always in the body. So that's the same in the head. Now, if this, I'm not really sure that this has the same structure as the dura, that you can call this a real periosteal layer of dura. There are 2 schools of thought, and the one says this is just periosteum. So when you're opening here, what you're opening is periosteum, but what you see sometimes in surgery is that you come across a very lucent, and you've also seen this in the movies that have been presented by Dr. Tabrano, you come across this lucent substance which really looks like dura and not periosteum. So the the two schools of thought, they're not really agreeing with each other at this point. But that's not important. What's important is that you see these venous lakes here, which have just like one layer of cells. That's the beginning of the cavernous sinus. That's the beginning of actually the venous plexus. And this is 18 weeks, and you also already see the nerves being formed, and this is 28 weeks, and this is when the cavernous sinus is already formed. You see the internal carotid, and you see that these lakes, they come together and they form these very large sinus-like spaces. But this is not a sinus. It's not enclosed by two layers of meninges. It's not. And two, it's not actually a sinus because it's not a venous lake. It's a plexus of veins. So I fully agree with Parkinson when he said that we should no longer call the cavernous sinus because it's neither cavernous nor sinus. It's a lateral cell space. So this is what you've been looking at. This is just a corneal section at the level of the pituitary gland when you're looking at the third, fourth, sixth nerve, ophthalmic, maxillary going to foramen rotundum, and the two layers of dura. What I also want to note is the only nerve that is actually in the cavernous sinus is the sixth nerve. The rest, they're encased in a layer of dura, which we'll see soon. The first operation done by a surgeon in the cavernous sinus is Volovici. He was a Finnish surgeon, and he operated on a very large schwannoma in 1895. But the actual operations in the cavernous sinus began with this guy, and he's Dwight Parkinson, and following in the lines of many very exquisite Canadian neurosurgeons. He's also a Canadian neurosurgeon from Manitoba. But just as Drake, who's the foremost authority on operating on the posterior circulation aneurysms, which is also from London, Ontario, in Canada, but has the greatest series and the best results to this day. He follows in the line of great Canadian neurosurgeons. And I think, so he's the first one who operated on the cavernous sinus, and he's also one who's become, I wouldn't want to use the word obsessed, but it's close to that. Because if you look at every article that's been published on the cavernous sinus since 1980s, you'll see that he's actually almost answered to each and every one of them with his opinion. He's done some amazing research in the cavernous sinus, but he's remained, to his death, to his last article in 2000, dedicated to not only the surgery but also the anatomy of the cavernous sinus. But the real man who operated and who made this possible is Winkel Dolenz. And his paper in 1983, that was a landmark paper with microsurgical repairs of intracavernous vascular lesions. That was a landmark paper published in the Journal of Neurosurgery. And those of you who came to Cluj know this, but he actually likes telling people sometimes that his paper got rejected the first time he sent it to the Journal of Neurosurgery. He still has the rejection letter somewhere in his office. So that's just, and then it got accepted obviously, and he was the cavernous sinus man for him, he still is actually. So if you have a great idea, don't give up on it, because you might just become great in your field. So this is the first ever very good dissection of a cavernous sinus by Parkinson in 1965 in his first article on the cavernous fistulas, and you already see the amount of detail which he put into this, because if you look here, you also see countless capsular arteries, meningeal hypophyseal trunk, the infralateral trunk with perfect localization. So this is an overall excellent article, and he started what would be an amazing journey through the anatomy of the cavernous sinus. At the end of his life, this is actually his concept of a total epidural venous space, extending from the coccyx all the way to the orbita, and that would have as a center the cavernous sinus, because the cavernous sinus receives venous drainage from from the ophthalmic veins, from the sphenoparietal sinus, and then and also sometimes from the circular sinus, which we'll be talking about soon, and then it deploys it via the inferior petrosal sinus into the sigmoid sinus. And this is very important because the superior petrosal sinus is not the main pathway for which blood goes to the sigmoid sinus, and that's why you can divide it if you're doing a transpetrosal or a Kawase approach, because otherwise if you would be cutting out the principal supply to the sigmoid sinus from the cavernous sinus, you will have here a cavernous sinus thrombosis, but that's not the case because the superior petrosal sinus you can divide. And what we also see is that Parkinson, he did amazing corrosion, which is one of the best casts that he made of the cavernous sinus and the venous anatomy around the sella. But we should also not forget Taptas, who was the first one who told everybody that the cavernous sinus should be named otherwise and should not really be considered a sinus in the first place. He's the first one who drew attention to that in a very good article. Now, Rotan, one of his first articles was over the cavernous sinus in 1975, and you see even at that time his dissection skills were marvelous, and the amount of detail which he put into this, so it's optic, oculomotor, mechal scathe, dissected it, everything's there. This is what we're slowly heading towards. This is the actual cavernous sinus, so this is the region we're talking about here, all the way to the top of V1. And you have to know that the nerves which are going into the cavernous sinus are 3, 4, V1, and the 6th. And what is inside the cavernous sinus? The carotid. And what's also inside the cavernous sinus? A plexus of veins. And this is an excellent article which settled, in my opinion, the discussion on what is now the lateral wall of the cavernous sinus. Because this was on the cover of the Journal of Neurosurgery in 1982, what you see is that there are all sorts of schools who said that either the carotid was too medial, or this was one giant sinus and regulations, or that it was stuck to the medial wall, or that it was superiorly. And what we think of now as the cavernous sinus is this one, G, thanks to Umansky and Nathan. And this is what we consider right now as the cavernous sinus. So what you see is this the temporal basal dura, and it splits here into 2 layers, or if you don't want to consider the periosteal layer as a layer of dura, then it just goes above all the nerves. And what you see is you have a very thick dura here on the outside, and you also have a very thin layer on the inside covering all the nerves. And what you also see is that the dura goes across the cavernous sinus as if you were putting a cover on a chair. And why is this important? Well, it's important because if you're coming from inside, if you're coming from intracranial, then it's going to be very difficult to open this without damaging the nerves. So what you want to do, and what we're going to be seeing in the transcavernous approach, is you want to peel off the dura. So at every skull-based course that you're going to go to, you're going to be taught how to peel off the dura, because that's the most important aspect of this operation. You're going to peel away the dura so that you have these nerves inside, and then you have access to the cavernous sinus. So that is here. This is the temporal basal dura, and once it's been peeled off, you can see the Gasserian ganglion, you can see V2, V3, foramen rotundum ovale, and the nerves that are going into the superior orbital foramen with the frontal lacrimal branch, and you see here the cochlear that's going above the oculomotor nerve, which splits here just after the superior orbital fissure. It splits into superior and inferior trunk, and the trochlear nerve that goes above it and medially to the superior oblique muscle. This is an article by Rota and a team from IMD. So just remember this one. This is the best cavernous sinus drawing so far. Now we're going to go a little bit into the anterior glenoid process. You should tell me if you can't anymore. So what we want to see here is the cella from above. And what would this be? Well, if you look at it, it's the tentorium. And it's very important for later, for when we'll be talking about the triangles in the cavernous sinus and the middle fossa. But what you also have to see here is that the dura on the anterior glenoid process has a superior and an inferior surface. And why is that important? Because the carotid has two carotid colors. It has two carotid rings, dural fibrous rings, and one carotid color. You've probably heard about them, but you're probably still wondering what they are and why they're so important. And we're going to be discussing that in a minute. But what you see here is that if you're going to drill out the anterior glenoid process, then I want you to remember this, because this is the optic nerve in the optic canal, which we've unroofed. This is the falciform ligament. This is just the continuation of the dura on the superior side of the anterior glenoid process. And this is the superior orbital foramen. And all the nerves are going this way. And we're going to see that that's very important for when you're doing the anterior glenoidectomy, because there's dependence of dura here which you're going to have to cut. And the question is, all the time, always, is which direction do these nerves go to so that I don't injure them when I cut? And we're going to get back to that. What you also see is that the carotid has a superior ring or a distal dural ring and an inferior ring or a proximal ring or Pernetsky's ring. That was a Hungarian neurosurgeon who did a lot for endoscopy and who worked with Professor Heinz. And you also see you can insert a spatula here in this thin layer of dura, and this is the carotid collar. And this is important because an aneurysm here is not going to grow upwards because of this very thick fibrous color, but it's going to invade here in the cavernous sinus. And what's also of importance is that the oculomotor nerve has a triangle here with its very own cistern, arachnoid cistern, which you can pierce. And why is that important? Because when we're doing the true transcavernous approach for example, aneurysms of the basilar artery, what you want to do is you have to unroof the oculomotor triangle in order to free up the oculomotor nerve and dissect this oculomotor carotid triangle. Why do you want to do this? Because this is the posterior glenoid process. If you drill this out, you're going to come on the basilar artery tip. So that's your way of accessing the basilar tip aneurysms. And you're going to probably ask me, why do we have to do this? Because we could just separate the carotid from the chiasm and the optic nerve. Why wouldn't we do that? Because all the perforators from the carotid and the anterior choroidal, they're going this way. So if you stretch them out too much, anterior hypophyseal, inferior hypophyseal, meningohypophyseal, trunk perforators, you risk injuring them all. Professor Keller also proposed a new and I think the best segmentation of the carotid artery. So let's just for a second think about this. This is C1, cervical, then the carotid duct, then the C2, that's the petrous carotid, and then C3, lacerum, then the heterolingual ligament, and then C4, which is the cavernous carotid, C5, which is now named the clinoidal. And where is the clinoidal? It's between the two fibrous dural rings. So that's why it's important. But sometimes the proximal ring is so loose that you actually have cavernous sinus venous blood coming all the way here. So you actually have a cavernous carotid that spread out along this entire path, and then you also have kind of down in the communicating segment. This one is also a very good article for anatomy aficionados, and it's from a Turkish group of neurosurgeons and anatomists who said that they find that it's pretty bad that nomina anatomica, which is the Association of Anatomists, which they agree upon every year how all the structures of the body should be named. They named meningohypophyseal trunk for posterior trunk because it comes out posteriorly, and the infralateral trunk, they called it lateral trunk, and this one, the tentorial basal branch, we call that Bernasconi cancinari tentorial artery, they call it tentorial basal branch, and there are a lot of differences. So if you're interested in that, they propose the full nomenclature, but that's really not going to happen anytime soon, because everybody who's in neurosurgery is going to use the names that Rotan and Parkinson gave these arteries. But if you're interested in the actual nomina anatomica correct names, then you should check out this article, because they also have some pretty good dissections, albeit in black and white. So this is the carotid, the cavernous carotid. It begins here at the ligaments. It gives out the meningohypophyseal trunk. This trunk occurs in 100% of the people. In all the studies, this is always present. This one, the infralateral, it occurs in 80% of the people, and Meccano's capsular arteries for the capsule and the diaphragma celli, they occur in about 20% of the people. And what you also see in the cavernous carotid is it has 5 segments, according to Rotan. And why is that important? One is important because I couldn't find anybody so far to explain to me why the cavernous carotid has such a tortuous and very weird trajectory inside a stretch of very, it could just go from here to here and nothing would happen, but it has a posterior vertical segment, a posterior bend, a horizontal segment, anterior bend, and anterior vertical segment. So there's nobody that can actually explain to me why it's so tortuous. And why is it also important? Because you have a lot of venous spaces that occur inside the cavernous sinus, and the most important are the posterior superior above the posterior fold and the anterior inferior underneath the posterior fold. And what they are is, you'll know during surgery where it's going to bleed the worst. This is again only to show you, if you're removing the anterior clinoid, then you're left with a clinoidal triangle. And what does it have? It has the optic strut, the clinoidal carotid, and this, the carotid oculomotor membrane, not to be confused with the carotid oculomotor membrane, which is an arachnoid membrane. This is a dural membrane. And it's also the roof of the cavernous sinus in its posterior side. So this is actually the roof of the cavernous sinus here in the clinoidal triangle. So that's why important. If you're removing the anterior clinoid, you're actually gaining access to the clinoidal triangle. What's also important, and that's Kobayashi, a Japanese neurosurgeon who loves this very much, is a carotid cave, which occurs in about 70% of the people. And what you see is the distal dural ring attaches very firmly to the side of the carotid artery. But if you look at it medially, it doesn't. It doesn't form a very definitive structure. So what it does is it leaves this carotid cave, and what you see is that very often the superior hypophyseal artery arises inside the carotid cave. So if you have a superior hypophyseal artery aneurysm, which are exceedingly rare, but they exist, they might have very important involvement here and also in the cavernous sinus. And if you want to look at a severe hypophyseal aneurysm, I think Lawton published one. It's on YouTube on the ANS channel. You can just look at it for free. If we decide to excise all of the cavernous sinus, then we're going to be left with this. equatorial edge, anterior petroclinal fold, and the third nerve going inside the oculomotor triangle, as shown earlier. And this is just to illustrate again the bending of the carotid artery. So as you see, it has a posterior vertical segment, a posterior bend here, which is usually at the same level of the posterior clinoid process, then a usually horizontal, but here is more tortuous, so it's not really a horizontal segment, then an anterior bend and the anterior vertical segment, all the way to the distal dural ring. And once again, if you remove the anterior clinoid, you see here the carotid collar. This is the carotid collar, so this is the clinoidal carotid. And if you drill out this area here, between these two triangles, then you come inside the sphenoid sinus. And it's also good to remember that all these regions have a connection with the axial base, so with the external cranial base. So you have here V2 going through Foramen Rotundum in the pericarpal fossa, and you see the birth of the median nerve. You see the greater petrosal nerve running above the petrous carotid. We'll be talking about that at length tomorrow. And I just want to show you the relationship of the nerves as they enter the superior orbital fissure. It's short. What you see here is that the nerves are coming to the superior orbital fissure. The anterior clinoid is removed, and what you have to remember is V1 splits into a frontal and a lacrimal nerve, and also a nasociliary nerve. And for those of you who will be operating inside the orbita, this is the annulus of Zinn, so the annular tendon where all these muscles insert, and the frontal and lacrimal branches, as well as the fourth nerve, which is going on medially to the superior oblique, are going above the tendon, and third nerve, sixth nerve, and the nasociliary branch are going through the annular tendon. And that's really important when you're operating in the orbita. And you see here that once you've crossed the superior orbital fissure, then you have a superior and inferior division of the third nerve. Now, triangles, everybody loves triangles. The only important thing is what are you going to do with them? I really don't care if somebody can perfectly describe the inferoclival or inferolateral triangle. The idea is, why do you need these triangles? Do you need these triangles because you want to know what you're going to do with them? So for instance, if you want to expose the clinoidal carotid, then you're going to take out the anterior clinoid process, so that's the clinoidal triangle. If you want to expose the oculomotor nerve, then you're going to open the oculomotor triangle. This is infra and supratrochlear triangle. Why are these important? Because they give access to the cavernous carotid. And the infratrochlear triangle is called Parkinson's triangle because this is the one which he used to gain access to his first carotid cavernous fistula, and to the inferolateral trunk, which goes above the abducens nerve. And this is anterolateral and anteromedial here, and I showed you in a previous dissection that if you drill here, you're going to come inside the sphenoid sinus. And then, so what you have to keep in mind is there are 4 triangles of the cavernous sinus. There are only 3 here. 4 triangles of the middle fossa and 2 of the clivus. The infralateral one is to show you where the origin of the trigeminal nerves goes through the porus trigeminus to the Meckel's cave. So that's why it's so important. And the other one shows you where the abducens nerves goes inside the Rell's canal. 4 and 5 are anteromedial and anterolateral. They're going inside the sphenoid sinus. And posteriorly, so on the posterior aspect of V3, you have the posterolateral and the posteromedial triangle, and they're divided by the GSPN, the greater superficial petrosal nerve. And this is Glasscock's triangle, that was a otologist, a neuro-otologist. So if you drill out here, you're going into the infratemporal fossa to do an abdominal bypass before though. And if you're drilling out here, you're drilling out the petrous apex or cavazis triangle in order to come on the side of the clivus and the anterolateral side of the brainstem, as we're going to see tomorrow. So triangles are only important if you know what to do with them. Now, the Dulwich approach always begun with the epidural approach. So we're going to do a large craniotomy and separate the frontal and temporal lobes. And here, when it gets complicated, because you want to drill out the anterior plantar process, but you have this fold of dura, which is variably called the meningo-orbital fold, or the frontotemporal orbital dural fold, etc. It has a lot of names. But the idea is, how do you cut this? Because you have the optic nerve going here, and you have the superior orbital fissure here. How do you cut? You see, this is what you would normally do. This is frontal dura, this is temporal dura, and this is the meningo-orbital band. But what young trainees find very difficult here is to get a 3D orientation of where is the optic nerve and what is exactly the way that the nerves travel here to the superior orbital fissure, so that you know that you're not going to be cutting the nerves. So what Professor Morkos out Florida did is he proposed that you first elevate the dura from Phi2 and Foramen Rotundum, and then work your way towards the cavernous sinus. So you have this very wide approach. You know that the nerves are running here, so you can cut it very simply. But then Professor Froelich, as usually happens in skull-based surgery, came and said, yeah, that's a very interesting modification of the Dulwich approach, but it's not really necessary, because if you look at this histological plates, this anterior plantar process, this is optic strut, then you realize that all you need to do is just elevate here the dura a bit and cut in this direction. So let's get ourselves oriented. This is the anterior plantar process. Your patient is positioned like this. So you're going in from lateral, and you're drilling out here. This is periorbita. So you've drilled out the roof of the optic canal and the lesser wing. And what you should have in your mind is which way do the nerves travel. And you see here superior ophthalmic vein, lacrimal nerve. So this is the way, and you're going to cut perpendicularly and above. And then when you've done that, you see here the V1 going to superior orbital fissure, and then the anterior plantar process exposed. And this is in a cadaver. So you see here the meningo-orbital band, which you can cut, and then you're going to be unroofing the optic canal and uncovering the carotid artery, second nerve, and kleiner tip. Now, I want to first show you a movie before we go any further. I'm going to show you how you do anterior cranioidectomy, because we've talked so much about it, but we haven't really done anything. So this is a lady who had Wegener's granulomatosis, and she had loss of vision. And loss of vision was because the dura of the optic nerve was so thick that it was compressing on her optic nerve. And she had to be treated with dexamethasone, very, very, very toxically high dose every day to not lose her eyesight. We actually published this case because it was so interesting what the indications are for optic decompression. So what you're seeing here is just a regular craniotomy, frontal dura, temporal dura, and you see just a very large cutting drill. You're going to be expanding this frontally. This is temporal muscle, so you know where you are. And what you want to do is, you know that here when you're going to split the frontal and the temporal dura, you're going to be coming across the anterior clinoid process. So this is exactly the situation that we had in the paper I just showed you. So we're cutting the orbital band, and we know that the optic nerve is running this way, and the nerves of the superior orbital fissure are running this way. So we have no problem. We don't have to elevate the dura from foramen rotundum all the way to here in order to expose the anterior clinoid and cut the middle orbital band. So we're just going to begin. It's still fixated obviously on the optic strut. First you have to use a rotan dissector to make it free of all other dura and loose connective tissue, and then you use a 2 millimeter diamond burr. Professor Christ, who's actually the one that popularized this technique, uses a 1 millimeter diamond burr, but 2 millimeter is also good if you know what you're doing. And then what you're going to do is you're going to drill out in a sort of eggshell technique. And once you've done that, you can remove it with a bone ranger, and you leave the tip there. And let's get ourselves oriented. This is Cavernous sinus here, periorbita, and we're going to be opening the dura now because we want to expose the optic nerve, which has been compressed for so long. And we're heading just towards the orbit, and we're going to be cutting the dura above the optic nerve. This is the also rotan dissector, and this is the diamond knife to cut the dura. And once the optic sheath is dissected on the optic nerve, which is running and going towards the orbit, we decide, so you can see that the dura, we're obviously using the normal cone. What I want you to see is that the optic nerve, and it's always doing this, the optic nerve at the end was just lying open. Sorry, this is not going to work. But what we wanted to do is the dura was very thick because it was chronic inflammation, that's Rayner's. So when you opened it, you saw the nerve just decompressed, but a little bit white. So one of the patients in our series did well, and the other one did a little bit worse. So when it comes to approaches to the cavernous sinus, this is just the last thing I want to talk about. You have this article by Volovici and Libas, which is an amazing anatomist and also professor from Sao Paulo. And they present a series of cases which they've done of the cavernous sinus. So what you're seeing here is the carotid, A1, and here is a very small aneurysm, early temporal branch, M1, and this is the posterior clinoid process. So if you would translate this one into a cadaver dissection, it would look like this, A1, M1, posterior clinoid. And then they drilled it out, dura of the clivus, posterior fossa arachni, they open it up and you see a basilar tip aneurysm. So they did a real, true transcavernous approach, which would be equivalent to this for basilar tip aneurysm. This is a patient with Cushing disease and the rest recurrent disease, and she was 16. So they decided to go in and do an intracavernous resection. You see here the optic nerve, V1, V2, fourth cranial nerve, and this is the end of the operation. You see that the resection is complete. You see the posterior clinoid, you see the clinoidal segment, pituitary, cavernous, carotid, V1, and the cavernous sinus, which is open. They've also done some meningiomas in the cavernous sinus. Post-op result, the mengiomas not fully resected. But there's really no gold standard for cavernomas in the cavernous sinus, but what we do is very well explained in this article by Klingler, what to do with a cavernous sinus meningioma. If it's large and it's extra cavernous, you see here pituitary, carotid, nerves, you should debulk it and observe, and if it has a recurrence or symptomatic progression, then stereotactic radiosurgery or fracture and radiotherapy. And if it's primary intracavernous, then you're going to do this. This is what our center is also doing. But this is a resection of Professor Fukushima, and you see here a very large meningioma, and he's with an 11 blade. He's actually dissecting the meningioma from this is a trochlear nerve. And what you see at the end is a very wide resection, is the Assyrian ganglion P1, fourth nerve abducens. And if you look at this plate, you might wonder, hey, this looks like the cavernous sinus, but it's actually not the cavernous sinus, it's actually the suboccipital triangle, and this is V3, the vertebral, with suboccipital veins and the jugular vein running here. And this is actually an article by Professor Christ himself and Almefti called the suboccipital cavernous sinus, because if you look at it, it's actually V3 with two dural fibrous rings and a plexus of very important and large veins surrounding it. And it also has the weird bends that the carotid artery also makes in the cavernous sinus. So once again, what we learned today, a lot, I guess. Anterior clinoids, optic canal, how do the nerves run, third, fourth, V1, and don't ever forget this. The second nerve that runs in this direction and the nerves of the superior orbital fissure running in this direction. So if you're coming in laterally, in order to resect this, then you're going to be cutting like this. You're never going to have any questions about how the nerves are oriented in the superior orbital fissure.